when you lose estrogen, your body does a little 180, and instead of storing fat where it normally did, which is around your hips and your breasts and a little bit in your thighs, it shifts and suddenly you start storing fat around your midsection.
Yeah.
Kind of change from being a pear shape to an apple shape. And some of this has to do with changes to insulin sensitivity. And if that's not addressed over time, it can snowball and turn into metabolic problems like diabetes. Then the other thing that happens to us is our testosterone's quietly dropping. It is not a menopause problem. Testosterone falling is not really a sign of menopause. It's just when you hit 40, 50, it's already been dropping for 10 or 15 years.
Oh,
And
wow.
now it's at a low point where you start to feel it. So it just happens to coincide with menopause, but it's not happening because of. But when you lose that testosterone, a couple things happen. One is you kind of lose your motivation to do anything. Just want to sit on the couch. The thought, you might think about exercising, but to actually get up and go do it is a bit of a chore. And women complain all the time of having lower energy. They just don't feel like doing it.
Welcome to another episode of the Wisdom in Bloom podcast.
Yeah.
I am Kamisha, and this is my lovely host, Denise. And today we are joined by the wonderful Dr. Hatfield again to talk with us about all things menopause, more specifically, HRT and treatments and things like that. What can we do to help ourselves, ladies?
Yes.
As we are going through this wonderful stage. Yes. So we are excited to welcome her back to the show. Let me just remind you, Dr. Christine Hatfield is a licensed gynecologist with over 30 years of experience in women's health. Sorry, not mental health, women's health. She is a member with the Royal College of Physicians and Surgeons of Canada, the College of Physicians and Surgeons of British Columbia, the North American Menopause Society, and the Canadian Board of Aesthetic Medicine. Dr. Hatfield is also the medical director of a busy anti-aging clinic in Vernon, British Columbia. Esprit, is it Esprit or Esprit?
Esprit
MD. She is an expert in bioidentical hormone therapy, pelvic floor disorders, female sexual dysfunction, and aesthetic medicine. Dr. Hatfield uses a holistic approach to guide her patients through the menopause transition, helping them find their spark again. And we are so excited to have you back with us on the Wisdom in Bloom show, Dr. Hatfield. Welcome.
Yay! Welcome.
Excited to be here. Thank you.
Yeah, thank you. So Dr. Hatfield, one thing I wanted to say was, again, I said it before we push record. I'll say it again. Thank you again for joining us. We absolutely had a phenomenal conversation the last time you were on, and I promised you that we would bring you on again because that conversation was so lucrative and impactful to so many, that World Menopause Day is coming up in October, and I thought, man, this would be the perfect opportunity to bring Dr. Hatfield on again as we air this episode during World Menopause, and we dive a little deeper into some of the treatments and some of the questions that we had before, and just kind of take a deeper dive into them. So thank you so much for coming back to be with us. We really appreciate it. We're going to dive right on into HRT. So we talked a little bit about hormone replacement therapy last time, Dr. Hatfield, that you were on, and we wanted to kind of talk about it a little bit more because we know that HRT it's like the gold standard. It's like the number one thing when women are going through menopause. It's that number one treatment that they're offered. It seems to be the first thing that is offered now, even though there's so many other new and phenomenal things that are coming aboard. Can you tell us the different types of HRT available and how it might benefit us most, and how women can navigate through those benefits?
Yeah, I can for sure, because it can be a little bit confusing. And HRT is just a blanket statement that covers a variety of different compounds that we've got as physicians in our medical toolbox. So just to clarify, for the most part, HRT is referring to some form of estrogen and progesterone. And then depending on the provider you're working with, you might also be recommended to take testosterone. And then a deeper dive, some people may even include DHEA and pregnenolone as part of their HRT package. It really just depends on the provider and the level of education they've had and their specific area of interest. Now that HRT can then be further subdivided into this idea of bioidentical and synthetic forms. Now in 2025, I feel pretty comfortable to say that most of the HRT that's being recommended is bioidentical. So if a woman's going to her doctor and says to her physician, I'd like to be on bioidentical hormones, and her doctor says, oh, I don't do that, she can rest assured that usually that means her doctor doesn't quite understand what that term means. So bioidentical means that it's an identical match to the hormones that your body once produced. And for estrogen, we have that available as estrogen gel, as estrogen patches, and as tablets that you can take, and then also in the pellets that go underneath the skin. Progesterone also exists in a bioidentical form, and commonly it goes by the trade name of Prometrium. It's generic as well, or it can be compounded, but micronized progesterone is that bioidentical form. Years ago, when HRT was not as commonly prescribed and bioidentical hormones sort of came up in the late 90s, early 2000s as the thing to do, as deemed somewhat to be safer. At that time, we were still prescribing more of those synthetic hormones or hormones from other sources that are not human identical, such as Premarin, for example, which is an older form of estrogen replacement, or that synthetic Provera, which is a progestin, or I would say progesterone-like compound, but those aren't commonly prescribed anymore. So that idea of bioidentical hormones got mixed up into the whole idea that, oh, these are somehow compounded or somehow not real medicine, but that's not true. Does that help?
Yeah. So, but when you say bioidentical, is it identical to each woman as their bio makeup, or?
Yeah, that's a very good question.
Yeah.
So typically the word bioidentical means the hormone itself, what you're picking out from your pharmacy, molecules in that compound look the same as what your ovary would have produced. But where we can take it one step further is really more individualizing the dosing for patients. And that comes with expertise and experience. So some newer doctors or doctors who are just starting to prescribe HRT now, and they haven't been comfortable doing it all their career, and they're just bringing it in, they're probably not going to be individualizing dosing. They'll be using very standard, this is the what's available. But in my practice, I do try to do that for my patients because we're not all built the same. So part of the process is figuring out exactly what Kamisha needs, or exactly what Denise needs, or what Christine needs, so that she can feel her best.
Now, I wanted to ask, are there any potential risks with some of these hormone replacement therapies? Some of you mentioned estrogen gels and patches and things. Are there things that women should be concerned about when taking them?
Starting with synthetics, particular too, because a lot of doctors are not familiar with bioidentical, and they won't tell the patient. They'll just prescribe them the synthetic,
Right. Okay. So carrying on that line, before I answer the question, there are some other hormone replacement options that I would say still fall under that synthetic category, like they're called selective estrogen receptor modulators, which is a big long name, or SERMs for short. That goes under the trade name of Duaviv. And there's also the birth control pill, which is very commonly prescribed because doctors are comfortable with the birth control pill. They use it to manage dysfunctional bleeding, or they certainly use it for contraception, or in teenagers, they're prescribing it for acne. So a lot of general doctors are comfortable with the pill, and they might recommend that in lieu of HRT just because they're more familiar with it. But to answer your question about side effects, yes, it depends on what you're being prescribed. So in general, bioidentical estrogens carry a low side effect profile, but it must also be looked at in the individual woman, because some people are more prone to certain conditions because of their personal or family history. And some things that have been attributed to estrogens have been potentially the increased risk for blood clotting. So that would be getting a blood clot in your leg, or an increased risk of changes to the breasts, such as fibrocystic changes, which is painful cysts that happen inside the breast tissue. And there's always that question mark, that big question mark about, does estrogen increase our risk for breast cancer? And I don't think it's a clear-cut answer, yes or no. We're still trying to figure that out. Otherwise pretty safe. Where it becomes concerning is in a woman who has other risk factors. So if she's a smoker, or if she's over the age of 60 and looking to start hormone therapy for the first time, if she has a history of any type of cardiovascular disease, such as high blood pressure, or if she's previously had a stroke or a heart attack herself, or does she have a personal history of breast disease, whether it's benign or malignant, these are the people that we are a little bit more cautious about starting on estrogen until we've had a chance to fully evaluate them and make sure that it's safe.
Yeah.
Progesterone carries very few negative side effects. Some nuisance things when you take progesterone. Some people will say they feel a bit groggy the morning after they've taken it, or they might have a little bit of upset stomach. And there's a small percentage of people who paradoxically feel worse on progesterone. But for the most part, it's pretty well tolerated. And there's no health risks associated with progesterone that I'm aware of. And then if you end up being prescribed testosterone, the number one concern is the effect that it has on hair, increasing hair on the body, increasing hair on the upper lip and chin. And for a small number of people, if you're prone to or very sensitive to testosterone, it can increase the loss of hair on the scalp, which is already happening to women in perimenopause and menopause. So we have to just really see how the individual responds, but I would never want anyone to be afraid to start testosterone simply because she is worried about hair, because it can be started at a very low dose and just go slowly and see how your body responds.
Wow.
That makes sense. You mentioned birth control pills also.
No, I was looking at that. I'm thinking
you were thinking the same thing of therapy, and I had not heard about that before. Is that recommended, or is it preferred that you actually use a different form of replacement versus?
In my opinion, I think it's not the best form of hormone replacement because it is not mimicking what your body would naturally produce. And birth control pills have a much higher amount of estrogen than typical HRT would have. And it also contains a synthetic progestin. So those risks that we talked about before with cardiovascular and blood clots and issues with breasts are going to be more likely to be seen with the pill. The reason it gets chosen, I think, as I already said, simplicity, being comfortable with it. But the other is because women going through perimenopause who are in that stage where they're bleeding all the time, and their cycle is irregular or very, very heavy, the birth control pill can be very powerful to get that under control. So if that's the primary symptom, it can help. It will also reduce the hot flashes, which then helps with sleep and it's a little bit of a domino effect. But it wouldn't be my choice for a long-term solution, and women should not be really using the birth control pill as their solution for HRT for the rest of their lives.
Wow. I was just thinking, my brain went right to a visual of a 60-year-old or a 55-year-old using birth control pills. You got to remind yourself to take it every day, the same day.
They're probably out there, but I don't think they're using them for birth control at that point. But it's more just to manage the symptoms.
Yeah. Is there any non-hormonal medications out there that are quite effective to help a woman who's going through menopause?
Yes. So if you decide for yourself or with your doctor's help that HRT isn't right for you, there is some help for the most annoying of symptoms, which would be the hot flashes, the mood changes, and the sleep. So commonly, if we're not using hormones, we might consider some of these drugs as a means to help with mostly hot flashes, but they're not as effective as estrogen. So if we think about it, we have estrogen up here, gold standard, as you said before. The drugs, which I'll mention their names in a moment, sort of in the middle, helping about half as well as estrogen does. And then down here would be the over-the-counter supplements and acupuncture and lifestyle changes, right? Those things can help, but they're not going to be as powerful. So I'll list a few of them that I've used and that some of my patients have had success with. The first would be gabapentin. Gabapentin is a medication that is typically prescribed for nerve pain or to help with seizures, but it was found along the way that it actually slows down activity in the part of the brain that's responsible for regulating your body temperature, because hot flashes, although you feel them in your body, are actually a problem in the brain, in the center of the brain called the hypothalamus, where our body keeps all of our functions balanced. And one of those things that keeps tightly regulated is your body temperature.
Right.
When estrogen disappears, that system stops regulating properly. So gabapentin seems to calm that down. And when it's taken, usually it's prescribed between 1 and 3 times a day, it can be very helpful to reduce the frequency of hot flashes. And not too many side effects with gabapentin, which is nice. And it has this added benefit that when you take it at bedtime, it can make you sleepy.
That's a good benefit right there.
That's a good benefit. Another one that you might wonder, why would we take this, would be an antidepressant. Now, not just to treat the mood changes at midlife, but because they work by increasing serotonin, and estrogen and serotonin have a really close relationship with each other. And when estrogen goes down, your serotonin goes down as well. And serotonin seems to also be part of that regulation center for body temperature. So taking a low dose of an antidepressant, some common ones would be paroxetine or escitalopram or venlafaxine. Those medications on average will lower your hot flash frequency by 30 to 40%.
Wow.
So that's 50%. Lower your hot flashes by 50%. Compared to a placebo, though, a placebo, which is a sugar pill, will lower your hot flashes by about 30 to 40%. So they're not a lot better than placebo, but it's something. And if you are a breast cancer survivor and you can't take estrogen, then this can at least give you some relief. And they have the secondary effect of potentially helping with mood if that's an issue.
Now, do women take hormone replacement and then non-hormonal therapies together, or is it generally recommended that you kind of pick one? Either you do the...
Well, you could do them together if you had to, but probably I would anticipate that hormone therapy would address the hot flashes and you wouldn't need to take one of these other drugs. But if you are on hormone therapy and you're still struggling with mood, you and your doctor might decide that an antidepressant would be helpful for that.
Got it.
There's a couple others I can mention for your listeners. So one is an older drug called clonidine. It's prescribed for blood pressure many years ago. It's not a common first-line blood pressure medication today, but it helps to lower the signal of adrenaline in your body, so it can help with the flushing. So women who get that sensation where they feel the heat in their chest and then they feel it rise up and they beat red, the clonidine can help with that. But it's not, again, very effective when compared to estrogen. It only has about a 20% reduction in the flushing, but it's at least something. And then there's a newer one on the market now called Veoza, and its other name is fezolinetant. And this is a newer drug. It's called an neurokinin receptor blocker. Neurokinin is a molecule in the brain that has a receptor that it must attach to. So the medication sits on the receptor and then prevents the neurokinin B from attaching itself to that receptor. And that seems to, again, make the area of the brain regulating body temperature behave a little bit better. And we see a 60% reduction in hot flashes in the trials on that medication, compared to only 45% reduction on the placebo. So when you say it that way, it doesn't sound as powerful. If the placebo or sugar pill can get you almost to the same level of control as the medication, so it's slightly better than placebo.
Right. That was the the word that I was trying to say when I was emailing you, because
Yeah,
I had researched that was um, a new medicine on board that they were trying for hot flashes, night sweats, and falling estrogen levels as well. And so you're saying it's testing pretty well. Is that what you were saying?
it's testing better than placebo, but not very much above the placebo. So again, I wouldn't use this as my first line. If I have a patient in front of me and is having hot flashes, I'm going to recommend estrogen unless there's something in her medical history that would change my mind, which is then when I turn to these other potentially helpful medications.
You
And
know,
these ones you could combine together. I just had a patient in my office yesterday who's been diagnosed with breast cancer. She can no longer use her estrogen. She's taking clonidine, still having hot flashes. So we haven't got her maximized on the dose of clonidine, but I told her if these flushes continue, like she's having 11 or 12 a day and waking up wet in the night, we can combine some of these drugs together and see if we can't get her comfortable.
yeah.
That's good. I wanted to ask about the cost of this kind of therapy. So either the hormone replacement therapy or some of these other um, therapies, because at least here in America, medications can be quite expensive, and the prices, just seem to continue to go up. I don't know if you would even be able to answer this question in comparison to what happens in Canada, but I mean, do you know if these medications and treatments are cost effective for most women?
Hormone therapy tends to be fairly cost effective for most women. I can say what I can tell you in Canadian dollars that most of my patients, if they do not have coverage, are looking at about $100 out of pocket per month to cover their estrogen, progesterone, and testosterone. So that's reasonably affordable for most people. And then if you've got extended benefits and coverage, oftentimes those medications will be at least partially covered. Some of the compounds that I prescribe, if we're using testosterone as a compounded cream, for example, which is one of the few ways I can get it here, some drug plans won't cover that. Some of those other medications that I mentioned, like SSRIs and gabapentin, not terribly expensive because they're older medications. They're generic now. They've been around for a long time. So once they become generic, the cost goes down.
Right.
Veoza, I can't comment, but it being a newer drug, I would imagine it's probably still quite expensive because it's still on its brand name label. It might be.
Where does the GLP-1s fall into this whole scheme of things with the medications, with the menopause? How, because I know my husband is on a GLP-1, but it's because he's diabetic. And that was the first time we had ever heard of anything like that. But now I hear a lot of it with women using it for weight management, for menopause weight management, because we tend to start growing this inner tube during menopause. So where does that fit in all the scheme of things?
GLP-1 agonists are part of my protocol when I have a patient in front of me who isn't able to lose weight with the standard advice of exercising and changing her diet and trying to get more sleep and manage her stress. And the way they work is threefold. One is they reduce your appetite. So that's working in the brain and takes away cravings for things that maybe we know we shouldn't eat, that if we're trying to lose weight, like sugar, and takes away cravings for alcohol. The second way they work is they slow down the movement of food through your digestive tract. So you actually stay feeling full a little bit longer. And the third way they work is to improve your sensitivity to insulin and increase the production of insulin by the pancreas. So you're actually working on your blood sugar regulation. And that's how they work. Using them for menopause is off label, but those of us who prescribe them see the benefits because our patients are going through body changes that are pretty distressing and often have nothing to do with changing the way they eat. They often come to me and say, I haven't changed anything. I'm eating and exercising the same, or I've even improved the way I eat and increased my exercise and I'm still gaining weight. Please help me. So we always want to first make sure that their other hormones are replaced, because when you lose estrogen, your body does a little 180, and instead of storing fat where it normally did, which is around your hips and your breasts and a little bit in your thighs, it shifts and suddenly you start storing fat around your midsection.
Yeah.
Kind of change from being a pear shape to an apple shape. And some of this has to do with changes to insulin sensitivity. And if that's not addressed over time, it can snowball and turn into metabolic problems like diabetes. Then the other thing that happens to us is our testosterone's quietly dropping. It is not a menopause problem. Testosterone falling is not really a sign of menopause. It's just when you hit 40, 50, it's already been dropping for 10 or 15 years.
Oh,
and
wow.
now it's at a low point where you start to feel it. So it just happens to coincide with menopause, but it's not happening because of. But when you lose that testosterone, a couple things happen. One is you kind of lose your motivation to do anything. Just want to sit on the couch. The thought, you might think about exercising, but to actually get up and go do it is a bit of a chore. And women complain all the time of having lower energy. They just don't feel like doing it. So when I get their testosterone and their estrogen optimized, we've combated those two problems of body fat shifting and get them feeling like they actually want to go and exercise. And then, of course, if you're not sleeping at night, you're not going to feel like exercising. And when you don't sleep at night, your hunger hormone, which is called ghrelin, it goes up. And that's been shown. I always think of ghrelin as like a little gremlin.
Yeah.
It's spelled similar. And if you're more hungry,
somebody need to come get this gremlin from me.
That's right. It's hard to lose weight when you're hungry all the time. And that's where, again, the GLP-1 can be really helpful. And I've noticed that there's a bit of a positive feedback. Once a woman starts to lose weight and she sees that it's possible, boy, she gets more motivated to continue on the path and
confidence
keep well. Yes, because now she can go buy new clothes and she feels better about herself. So she's less likely to sit on the couch snacking on cookies when she knows that she feels better.
Yeah. And it's almost like she sees it. I've been there before because at one point in my life, I lost like 80 some pounds. And I remember losing the first 10 pounds going, I can lose weight. I can do this. You know what I mean? And so it was just like this little motivation because at first you don't know if it's working. You don't know if you can do it, So I can imagine them seeing that those pounds, the difference in, decreasing and thinking, oh, okay, I really can do this, and I know with my husband, his eating pattern has completely changed. It's completely changed. I mean, he still eat, 3 times a day, but very small portions, and he's not always, he don't have cravings. Like he used to have a lot of cravings especially when he was first diagnosed with diabetes, he was sick in the hospital, but he doesn't have those cravings now. So there's something very positive that's helped with it, and I assume that those positivity things are flowing into our menopausal environment as well to help women as well.
Definitely.
Yeah, for sure. And I'm glad that you mentioned. Go ahead.
Go ahead. No, I was just going to say there could be some side effects with the GLP-1s that women don't care for. The biggest ones being nausea and constipation when you first start the medication. Although a GLP is something our body naturally makes, when you're taking it in this form, at first it can feel like a little bit much. The body just notices that it's there and it really slows down the gut. And that's where the symptoms come from. But the good news is with time that gradually goes away and it's very dose dependent. And what I do in my practice is I rarely put my patients on the full dose of 1 milligram. I keep them on a quarter to a half of the dose. Just that little sniff along with their HRT is enough to get them to a point where they're losing weight and they notice decreased inflammation. Their body feels a little less uncomfortable. Their joints feel a bit better. They can recover from exercise a little bit better. And as I said, they get that positive momentum that now I'm going to eat better. I'm going to exercise and then they're maintaining themselves beautifully.
Yeah.
No, I was just going to say, I like talking about the impact that your lower testosterone levels has on women during menopause, or I guess postmenopause, because I feel like it's not the hormone that we speak about the most. I feel like estrogen, and estrogen loss is the one that we speak about the most. But the testosterone level loss is one where there's a lot of, confusion for women and also even spouses, because I know I also experienced, this low level of energy and not really being motivated, and then feeling, bad because I felt like, oh, I'm just lazy, I don't want to do anything. And I think many women don't realize, what kind of challenges they are, that the challenges they're having can actually have to do with the testosterone levels, right? It's not just, oh, they just need to, get up off the couch, and start, doing a little bit more for themselves and for their family. Like, there's really some hormonal things going on. And I think that the testosterone impacts are the ones that seem to be the ones that are lesser known.
Yes,
that's absolutely right. There's been less research on testosterone. That doesn't mean there's no research on testosterone. We certainly do have research. We have research in North America. There's a big body of research that's been done in Australia. In that country, they have an approved patch for testosterone for women, specifically for women. So that's wonderful, because we can look at their experience and see that how powerful that is for the women living in Australia to have access to that. Whereas in North America, we're still a bit figuring that out, but it doesn't mean there's no research.
It's just moving slowly.
Yeah, it's moving a little slow. So I want to jump over to one thing that I know that you specialize in as well, Dr. Hatfield, and that is vaginal and sexual health aids for women too. And I've heard a lot about menopause. It curbs the sexual appetite. The vaginal dryness. There's also many things that happen when we go through it. From moisturizers to low dose estrogens and other interventions, how can women continue to help maintain their intimacy as they're going through this stage of their life?
Well, the first thing I would suggest is that when you've entered menopause and you notice vaginal dryness, or even if you don't, have that conversation with your healthcare provider about the benefits of vaginal estrogen. And the confusion sometimes comes in that, well, isn't all estrogen the same? Well, no, when we're using vaginal estrogen in small doses, it's specifically intended for treating that area to keep the vaginal mucosa healthy. It's good for the lining of the bladder as well. And why we want to keep those tissues healthy is that it's much easier to preserve what you have than to try to correct it after it's disappeared, because the natural history is after menopause, your vaginal tissues, your vulvar tissues, which would be the labia, and the area around the clitoris, the urethra, everything shrinks and gets smaller and thinner. And when that occurs, we see dryness, we see pain, we see an increased risk of infections in either the vagina or the bladder. Some women will have bleeding. Some women will never be able to have sex again because they didn't tend to their vaginal tissues. So keeping that area optimized is the number one step. And even the good news is, even women who have been diagnosed with breast cancer and treated for that are still able to use low dose vaginal estrogen, because the risk to their breast tissue is very, very, very low. So we oncologists are generally comfortable with their patients using vaginal estrogen. So that would be my number one.
Is there anything over the counter that women can take for their, vaginal health?
Well, there are over-the-counter moisturizers and lubricants that women can use, but they're not going to keep the function of the tissues optimized, but they can be beneficial, especially vaginal moisturizers that contain things like hyaluronic acid and emollients like shea butter or vitamin E, things that keep everything feeling lubricated. It's just like your question before about non-hormonal medicines for menopause symptoms. estrogen always works the best. And then the other things that we have are helpful, but they're not going to be quite as good as using estrogen.
Right. They're more of like supports, but they won't really,
Right.
they won't
Support.
move the needle as much. And so can we talk a little bit about what those supports are? I think you mentioned sleep health is very important, and something about exercise as well. I feel like diet and exercise are always supposed
Yeah,
to be good.
Always comes up, huh?
Right.
always come up because they are super important. Okay, well, diet-wise, my main recommendation to my patients is eat a balanced whole foods diet that contains protein and fat and carbohydrate. Don't fall victim to fad diets, and try not to eliminate food groups unless you have a proven allergy to that food, because we need all of those nutrients. We need a variety of foods. We want our food as much as possible to be fresh, because then it's going to have the most vital nutrients in it. And that's the best diet advice that I can give. That's basic. But then there's a few little tweaks. And the first tweak would be the amount of protein you're consuming. We want to aim for higher protein as we get into the middle part of our lifespan, because our body has a bit of resistance to growing muscle. And the one job, if you will, that I tell my patients, your number one job after menopause is to keep your muscle, because it's disappearing if you don't work at it. And one of the tricks is to have a higher amount of protein every day, because that protein will trigger muscle synthesis, even if you didn't go to the gym. Now, I'm not suggesting you don't go to the gym, because we want that as well. But the protein by itself, if you eat a high protein meal, your body tips into that anabolic protein building phase for a few hours after the meal. So it's really important. And it's especially important if you're doing Ozempic or another GLP-1, because of the concern of losing muscle just due to the weight loss itself. Protein is really important. So a rough estimate would be 1 gram of protein per pound of your ideal body weight. And what's my ideal body weight? There's some calculators online you can use to figure that out based on your height. But you can think, what's the weight that I think I would feel my best at? That's your ideal body weight. And then transfer that in, or calculate that into grams of protein, and aim to eat that during the day.
Okay. That's the total during the day, not per meal. That's during the day.
Over the whole day, yes. And I would say the average woman is going to need somewhere between 100 and 120 grams. If she's active in the gym and she's lifting heavy weights, err on the higher side. But if you're an average woman, you're not working out particularly hard, around 100 is usually a pretty good target. And that's not hard to reach. An average meal would have about 30 grams of protein. So if you're having 3 meals a day plus a snack, it's doable.
Right. And I'm sure we should be reducing our sugar levels. That's
Absolutely
probably not helpful.
Yes, sugars fall under the carbohydrate categories. Remember, I said we want to eat carbohydrates, but they don't all behave the same way in our body. So sugars that come from whole grains and fruits and vegetables behave very differently than white sugar that comes from candy and baked goods and processed foods and white flour. And I never say you can't have a treat. I had a cupcake last night. It was a special event, but I balance it out with the rest of the week and try to eat well and not avoid, but I'm just aware not to make those treats happen more often than they should.
What about fasting? I see a lot of women on the whole intermittent fasting fad to try and help them as they're going through this. What is your recommendation, or what do you think about the whole fasting trend?
I think fasting can work for some people, but in general, if a woman fasts too often or too long, it can have negative effects, because it will lower your metabolic rate. And then once that's lowered, and if you stop fasting or you start eating more, you'll put the weight on and some. So fasting, I don't think works for all women. I tried fasting years ago when it was really was really starting to pick up popularity. And what happened with me is I would fast during the day And then in the evening, I was so hungry that I think I ended up eating more.
Yeah, all the calories.
All the calories and some. So it didn't work for me and my body. And
Yeah.
also, if you're exercising, fasting is not ideal because women are not men. And if men exercise fasted, it seems to work very well for them. But when women exercise fasted, and this is not true for everybody, because I know we're all different, but generally speaking, women will not have the same level of output for their exercise. Their workouts won't be as effective if they're fasted compared to eating something beforehand. So I'm not sure that intermittent fasting is the best approach. I really think we should be fueling ourselves throughout the day, but just be smart about what you're choosing to eat and watch the types of carbs you're choosing and make sure you're getting the protein.
That's really that's enlightening that you say that about men and women, because back a while back, like you said, when the whole fasting trend was really, prominent, me and my husband would do the fasting thing, and he would fast and he would still have energy and he would still lose weight. I mean, by the end of the week, he's lost already 8 pounds. I would lose 1 pound, but feel exhausted, bloated,
Yes.
and irritated. So yeah, I'm glad that you said that made the difference, because we women tend to be thrown into the category, well, and not shown that there's a difference between the men and the women. The men are doing this, and yes, they're getting these results. Their body makeup is so different than ours, and they don't tend to go through all the different stages and changes that we go through as we go from 10 year to 10 year to 10 year. It's like we are completely changing into totally different people.
Yeah, no, it's definitely a difference, because I actually had done intermittent fasting and it seemed like it worked better, to your point, Dr. Hatfield, when I wasn't exercising. So I would do the 16-8, where I would, just eat for 8 hours, which was essentially just skipping breakfast and eating kind of like a late lunch. But here this year, when I've tried to do the intermittent fasting, and I did it maybe like 5 years ago and it was effective. But now when I've done it, and I've also started going to the gym, right? Because I've, told you need to be lifting weights and building muscle and all. And I am looking at that scale and I'm like, there's no change. And I'm disappointed because I've added the exercise, right? So like now I've added the exercise and I've seen no change. But I think you make a good point that, I didn't realize.
The body's telling you, I don't like this.
Yes.
Yeah, exactly. Yeah.
And it's not working for me. I need to stop it and do something else.
Yeah.
Yeah.
I agree.
Well, thank you for that. So as we I guess wrap up, is there anything else you wanted to suggest, or anything else you wanted to share that could be good for women who are in their postmenopausal states? Any other things they could be doing or thinking about?
And on top of that, I want to add to, as you're saying, what else could be important. I would love for you to talk about too how important it is to find your tribe, a community, or support of women who are also going through this. Because sometimes it can feel so isolating and so alone, because people may not understand what you're going through, especially your spouse or partner or friends who are not feeling it or not going through it. And sometimes it makes you think you're crazy. Like, I really am going through this. I know I am. I feel it, but no one else understands what I'm going through.
We just have to increase the conversation and make sure it's happening and support one another. So I totally agree with you, finding your tribe. And you can find that tribe really anywhere that you go, that there are women, because we're all going through the same thing at the same stage of life. So if your friend group, your family, the people that you know at the gym, in your church, I've noticed at the local gym here that they're putting on more menopause specific programming, which is wonderful. And I think we'll see a trend more towards that. So I think your local gym is a great place to get information. Social media groups, following thought leaders like Dr. Mary Claire Haver, who she has a huge following, and she provides a network going on to the Menopause Society and finding the doctors that can support you. So whatever you're missing, you can probably find the support. You may have, it may not just come to you, you have to do a little bit of work to find it. But I think as women, we need to just be open to having those conversations and not keep it hush hush. And remember that our mothers went through menopause very silently and almost with some shame. And that's not true anymore, that now it can be discussed and recognized that this is something that we are going to go through, that we're going to have this transition. Our bodies and our brains are going to change, and we've got each other. We can hold each other up.
Yeah. And some of them went through it and mentally couldn't come out of it, you know. So
Yes,
it's so important
absolutely.
that we support each other. Yeah.
And you asked me, what else can women do to help themselves? Well, we didn't finish all the lifestyle chat. I had a few ideas about exercise I can share with you if you like, but
yes.
the main tenets for exercise would be, first of all, find something that you like to do and that you can stick with. Because if you hate going to the gym, then going to the gym isn't going to be good for you. But on the same note, I do want my patients and everyone listening to this podcast to understand that in order to build muscle, we've got to work for it. It won't happen just by going for a power walk with or without a weighted vest. There's no evidence that that will increase your muscle. What builds muscle is lifting heavy things. So if you hate going to the gym, maybe ask yourself why you hate going to the gym. If you're going to a gym where you feel intimidated, don't go there anymore. You got to find a gym where there's people like you, and they exist. Or you can work out at home. And thankfully, we have YouTube, we have access to the internet. There's lots of videos where you can start small, start with body weight exercises. And then maybe once you start feeling a little better about yourself and noticing some change and you're getting stronger, then perhaps you can add in some resistance bands or buy some weights for home. But eventually, I'd love to see as many women as possible flooding the gyms and doing the deadlifts and the squats and the bench presses, because that's how we get strong. And that's how we keep ourselves nice and strong for the future, so that we're not going to be falling and having issues with not being able to take care of ourselves as we get older, not being able to pick up our grandchildren. Because I think all of us and who are listening to this podcast tonight, probably, if they could see themselves in 20 or 30 years, would like to see themselves living full and active lives and not sitting in a rocking chair.
Yeah.
Yes, that is absolutely true.
I totally agree. Yeah.
Mhm.
Thank you. Thank you so much. What a great last parting advice, because that puts a visual out there. If you could see yourself in 20 or 30 years, what would you want to see? What would you want to look like? I mean, I really took that to heart. So thank you. Thank you so much.
Yeah. And ladies, go and talk to your doctor. This is a great time, I think, in women's health, where there is just so much innovation, and there's so many more doctors like Dr. Hatfield who are here for women and specifically women's health. And you can find more of them now. I know when my mom, was going through menopause, she was struggling. And it's not as though it won't be a struggle, but there are, doctors and supports out there now that can help you. So I encourage women. And since we've had our first chat, Dr. Hatfield, I've been telling my friends too, like, go talk to your doctor, find someone who can help you. Like, it's important to get, because I still think, even with all the information about the different therapies and treatments, women still aren't taking advantage of it. They're still unsure. They're still like, do I really need that? Is it safe? Is it, not good? Like, what can I do? While they're also not feeling great, So I want to encourage women
and they're talking
to do that.
They're talking to their family doctor and their internal medicine doctor, who don't know what they should do and who are not educated. So that also puts them into a state of unsurety. So yeah, you're right. Completely
Absolutely.
Right.
So I would encourage our viewers and our listeners to go out there and do some research and get some supports,
Good advice.
Yes. And I guess that's it, right, Denise? On another wrapping up another episode. Lovely discussion.
Another episode. Happy World Menopause Month Day. in October. This episode will air in October for World Menopause Day. Take that advantage to go and talk to your doctor, talk to your friend, find a tribe, talk to a support group, talk to someone about menopause and what you're going through.
Absolutely.
Yes.
Yay. Thank you so much, Dr. Hatfield. And keep blooming, ladies.
Keep blooming, ladies. Bye-bye.
Bye.